U.S. Reps webinar. Welcome to today's C-Rep and U.S. Reps webinar, Unlocking Health Through Movement, How Registered Exercise Professionals Should Prepare for Healthcare Referrals. I'm Graham Mulstrand. I'll be the moderator of today's panel. I'm the Executive Vice President of Community Health and Wellness for the American Council on Exercise and the immediate past president for the Coalition for Registration of Exercise Professionals and a board member for the Physical Activity Alliance. I'd like to welcome our esteemed panel for today's webinar. I'd like to ask each of them to introduce themselves briefly to the audience. And Lori, maybe we could start with you, please.
Thanks, Graham. It's so great to be here. I am Laurie Witzel. I'm National Vice President of Policy Research for the American Heart Association, and I also help lead the Physical Activity Alliance.
And Liz, please.
Hello, everyone. Thanks for having me today. I'm Liz Joy. I am a family medicine and sports medicine physician in Utah. I am the Chief Medical Officer for Lohr Health, and I serve as the Chair of Exercises Medicine for the American College of Sports Medicine, and I also chair the healthcare sector for the National Physical Activity Plan.
All right. And Laura, if you could go next, please.
Hi, I'm Laura Newsom. Again, like my fellow colleagues have said, thank you so much for having me today. I wear two hats today. I am a clinical exercise physiologist, and I teach at Radford University in the physical activity and exercise. Also, I am the current president of the Clinical Exercise Physiology Association.
Thank you. And Jeff, we'll finish up with you, please.
All right. Well, thank you again for having me. My name is Jeff Duran. I'm the Senior Director with Power Wellness. It's a medical fitness wellness management company based out of Chicago. I'm here speaking on behalf of employers, but also as I'm the current chair of the Medical Fitness Association. Look forward to talking to you.
All right. So thank you, everybody. And let's go ahead and dive in. Lori, maybe we could start with you, and if you could provide an overview of the Physical Activity Alliance and the It's Time to Move initiative and why it's so important.
Thanks, Graham. So really happy to do that. And it's been a wonderful opportunity to pull the physical activity community together around national policy and systems change that we need to do to really help promote physical activity across the population. So it was before COVID, we came together as a community and talked about the idea of trying to unite and speak with one voice. And it took about a year for organizations to come together and for us to form the Physical Activity Alliance, but we did that. And the Alliance has three important areas of work. One is the National Physical Activity Plan that Liz referred to. It is the roadmap for implementing the physical activity guidelines for Americans. Liz leads the healthcare sector as part of the plan. I lead the business industry sector, co-lead the business industry sector. It is such an important roadmap, and it's really great that right now we're working on kind of implementation areas of the plan, but we're going to start revising and updating the plan as we move toward the next iteration of the physical activity guidelines for Americans in 2028. We also have our policy, the policy area of the Alliance, and that's where we're working on these national policy and systems changes. And finally, the professional development part of the Alliance that really helps support those who are in physical activity and public health. So, bringing all three aspects of that work together has been really powerful. And we have many major initiatives, lots of work that we're doing, but one of our major initiatives is It's Time to Move, what we're calling our It's Time to Move work. And this builds on all the great work that Liz and, the amazing, incredible people we have in the field that, where exercises medicine has been doing such a foundational work through the years. What we're doing is building on that effort to do some of the really important policy and systems change efforts that make this seamless. So make it seamless for physical activity assessment, prescription, and referral to be integrated into patient care. It's not easy, but we've had a lot of success in our initial work in the last year. So looking forward to talking about some of our initial successes and where we're going from here. I know we'll have a chance to do that through the course of the conversation today.
So thank you, Lori. Liz, as a practicing physician working in a health network, can you tell us why this is so important and what the impact would be on the work and the health of your patients?
Well, I don't think we need to convince people that regular physical activity is good for health. I mean, I think we can kind of put that to bed. But it's actually helping people to be successful, with regular physical activity that gets to be the challenge, right? And I'm going to spend, I think, my time really talking about some of the resources that are available through exercises medicine and how we're really using that. And thanks for the shout out, Lori. We're using that to connect healthcare with health and fitness. And maybe I'll just start by saying that, the vision of exercises medicine is to make physical activity assessment and promotion a standard in clinical care, connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. And we advocate for really taking, in healthcare, we often do something called SBIRT, or screening, brief intervention, and referral to treatment. And maybe with physical activity, it's not so much referral to treatment, but really connecting people to resources, so that they can be successful with whatever physical activity path they want to take. So I'm going to start with screening. I think probably many people on the call have heard about the physical activity vital sign. This is a tool integrated into the electronic health record that serves as a prompt for healthcare providers to have a conversation with their patients about the amount of physical activity they're doing. Because let's face it, if you don't know how much they're doing or not doing, it's pretty hard to make a recommendation to either continue, to maintain, to do more, to do it differently. In
Or
order
start.
to start, right? In order to improve health. So the physical activity vital sign is a really important first piece of this. And Lori and others through the PAA have been working to integrate that through the HL7 process. So we're really excited about that, to really see that physical activity vital sign as a standard in the inclusion within healthcare systems and electronic health records. The next part is brief intervention. And brief intervention, may be as simple as physical activity advice and really personalizing that advice to the individual. Mrs. Jones, if you were more physically active, it might help with your blood glucose control and your diabetes. Or Suzanne, you've been telling me how tired you are and how you're not sleeping well. Regular physical activity might actually help energize you a little bit more. So personalizing that message is important. That's advice. Next would be physical activity counseling. Advice is a component of counseling, but counseling takes it just a little bit deeper, right? And we may use a variety of frameworks like the 5 A's framework, where we're not only assessing and providing advice, but we're assessing their barriers and we're assisting them, connecting them to resources, arranging follow-up, et cetera. Then and then one more piece of brief advice or brief intervention is the exercise prescription. And that may be, very similar to how, a provider writes a prescription for a medication. Now we're writing a prescription for physical activity, in terms of their aerobic activity, strength training. We really leverage the FIT principle. So frequency, intensity, time, and type. And we give people sufficient information for them to act on it. And we develop it together using shared decision-making. And then that last piece is the referral to treatment or connecting people to resources. And I think that's really what we're talking about today, but I didn't want to talk about that till you understand all the pieces that come before it. And, connecting people to, qualified people, to programs, to places are all a part of the EIM approach. And, some people are going to do more self-directed activity. We definitely saw that during the pandemic when more people walked for fitness, when fitness facilities were closed during the pandemic, which has been great. But, particularly for people who have low self-efficacy around physical activity, for people who have accumulated a number of chronic healthcare conditions as they have aged, you know what? They lack knowledge and they have fear around physical activity. Think about somebody who maybe has had a heart scare. Boy, they're worried about walking up and down the stairs in their house, let alone going to the gym. So connecting them to an exercise professional who has the requisite training and certification, goes a long way towards creating that kind of trust and safety that an individual will have with a exercise professional. And then on the provider side, making that referral. And maybe we can talk a little bit more about this, because turns out I have a lot to say on this topic. But I think that, physicians are going to be more likely to refer to somebody who has, again, the requisite training and certification, so that they are not worried that if they send somebody who's got diabetes and chronic kidney disease and hypertension, all these cardiac risk factors, that they're going to go to the gym and have a heart attack. So that's the approach we take, through exercise as medicine, is that SBIRT approach of screening, brief intervention, referral to treatment. But really, it's connecting people to resources, and it's connecting them to the resources that are right for the person, right? What they want and where they should be to have the best experience and the safest experience.
Sure, and the confidence from a practitioner's perspective for referral and for the patient that you refer are based on competence and character
Absolutely.
in order for those to happen. So Jeff and Laura, looking at this from the perspective of an employer and exercise professional that's a practitioner, how does this impact what you would offer and deliver from an exercise program and intervention perspective?
Jeff, do you want me to go first, or?
Yeah, that'd be fine.
Yeah, so, piggybacking on what Liz has defined about, once the prescription is written from the provider and who they send them to, matching that with an exercise professional, such as a certified individual, whether it be, a fitness instructor level all the way up to a more in-depth clinical exercise physiologist, allows, from an academic standpoint, a widespread of interest levels. And we're starting to tailor our education models to reflect the feedback from the providers, and know where to start with the baseline of this individual, develop an exercise prescription that is appropriate and integrated into their lifestyle. As I mentioned before, whether it be a fitness, simple fitness instructor, all the way up to a higher risk individual that requires a little bit more intensive supervision. So from an academic standpoint, we are developing undergrad and graduate programs that are tailored to the different avenues in which somebody who is interested in this as a profession can seek out their direction. And then we pass them on to people like Jeff.
Yes. That's the beautiful thing about what we're able to offer. I'll speak a little bit more on, as the Medical Fitness Association, our facilities have been doing the exercise as medicine program since they came out. And they do offer a safe environment for individuals to come and to be referred. The credential that the MFA has that is the highest in standard in the industry is the certified fitness facility, medical fitness facility, and that provides our providers assurance that when they're sending their patients to a medical fitness center or a fitness center, that they're going to take care of them. Our staff are all credentialed, all certified, all have 4 years degree or higher. We do risk management, safety drills, codes. Most of our facilities offer mock codes at least once to 3 times a quarter. So we've really put a lot of emphasis on training of the staff to provide that safe environment, so we can deliver the exercise as medicine program. As this initiative gets going, I think what we as employers have to understand or do is that the volume is going to increase. And so learning how to deal with more volume of patients coming in the door, you may not be able to do just one-on-one all the time. You may need to restructure your program. An example, what we do at Power Wellness is our program's called MyFitRx, and the way that we run it, we do the assessment. It's individualized and do a prescription, but then we categorize them into a certain mode of exercise, and then run it very similar to cardiac rehab, where it's supervised exercise, so that we can see 4 or 5 individuals at a time, which allows us to make the program affordable and also provide the supervision you need as well.
Sure, and I think for some of our participants today that aren't as familiar with the Medical Fitness Association facility certification, that does require that there's a physician that's responsible for medical oversight, and the facilities have to offer outcome-based programs across a variety of chronic conditions that would be better managed or perhaps even prevented if you get somebody early in terms of inactivity-related chronic disease. So for the panel, Liz, you mentioned the HL7 standard, which we probably need to share just a little bit more about what exactly that is. That standard physical activity measures is a critical first step, but what do each of you see as critical tasks as we prepare to implement that physical activity assessment and referral as standard of care?
It's okay, Graham. I can give a little more background on that and the work we've been doing.
Please.
So, I heard from as exercise medicine clinician champions were talking on different forums. I heard that one of their major roadblocks initially was, how do I need to get the physical activity vital sign or the exercise, the standardized measures for assessment into my EHR. And that took a year or 2, sometimes 3 years to get accomplished with their health IT team. And then I was talking to CDC and they were saying, in the midst of COVID, it sure would be nice if we had an HL7 measure for physical activity and it was embedded in EHRs, because then it would be a nice supplement to our national surveillance system. So we actually found the funding, and we knew this was a foundational step in our time to move work, that we get standardized measures across all EHRs in the United States, because we all have to be measuring the same thing for a lot of reasons. It's really important that our assessment is a core to to that opening conversation that clinicians are going to have with patients. So HL7 is an international 501c3 measure standardization organization. They develop measures that are standardized across the healthcare ecosystem. They are global, but obviously we're working with them in the US for now, but our work could be applied globally pretty easily. And it's a very rigorous process, and we got the funding necessary to engage in that process and build what's called an implementation guide. That has all of the coding that's necessary to integrate measures for physical activity assessment, prescription, and referral into the EHR, and so it can be integrated in the healthcare ecosystem, but also allow healthcare systems to talk to other entities so that those patient data can follow them on their journey toward active living. So it took about a little over a year to do that work in HL7. In last August 2023, we were able to publish the first version of our implementation guide. It's now out in the public domain, and we're working really hard to try to get integration and uptake by health systems. And so we hope maybe to have your help. If any of you on the call are associated with a health system, that maybe you might take that implementation guide back to your health system and see if it can be integrated into your clinical workflow. But we also knew that, okay, so we've got the standardized measures, but you really got to incentivize EHRs to get them into their systems. And how do you do that? You have to work with the Office of the National Coordinator and what's called the U.S. Core Data for Interoperability. That is federal regulation for all technology software, licensed technology software that there is a core set of data that all EHRs need to have in their systems. And so we applied to the Office of the National Coordinator to have physical activity assessment included in the health risk assessment or health assessment portion of US core data. And that was actually approved last July of 2023. So it's going to take a couple of years through federal regulation for that mandatory uptake to happen, but that we actually were just accepted by in the White House second round of commitments that said that we're pledging by 2028, the next revision and update of the physical activity guidelines, that we'll have physical activity assessment in all EHRs across the country. So that was a huge accomplishment, but obviously now that we've got to move on from here to continue this work. It's one thing to have the measure there, but we have to get this into the full spectrum of patient care.
Liz, from a clinician's perspective, what are those, what are those critical tasks that you see?
Well, all this work that, Lori just presented and talked about, I mean, it was so essential to have this happen. I mean, we've been talking about, integration of the vital sign for about a decade. And Kaiser Permanente and Intermountain Healthcare were probably the first two healthcare systems to do that. And that was really through the efforts of Exercise as Medicine. And then it's just kind of slowly kind of crept along, a little bit here and a little bit there. So it really took the leadership of the PAA to kind of, massively accelerate this process, to where we can get it to scale. One of the things that, we experienced, and I've consulted with, healthcare systems, all across the United States and in some internationally as well, is that, you have to, once you even have a kind of permission, within your healthcare system to have the vital sign, product placement matters, workflow matters. If the vital sign is buried, on some page deep in the electronic health record, I can assure you it doesn't get used. Nobody sees it. It's just these electronic health records are so complex that if you don't have good product placement, where it is seen, it is interpreted, and it is acted upon, then it doesn't do you much good. So, I hope as part of this process and, as part of our implementation efforts, that it's not only integrating it into the electronic health record, but really getting it into optimal workflow. Because you can have a great tool, but if you don't know how to use it, then, what's the point? The next piece of it is, when you have the information, then how do you act on it? And helping healthcare providers, and it's everybody, right? It's not just, physicians and advanced practice providers like nurse practitioners and physician assistants, but it's our dietitians and physical therapists, clinical exercise physiologists, everyone who is, working with patients, generally, at the point of care, can be utilizing, a physical activity vital sign as kind of a starting point, to kind of lead down the rest of that path. But they all have to know, what do you do with the information? Is somebody who says that they're getting, 60 minutes a week of physical activity, is that enough? Is it too much? Is it too little? Is strength training important to my 70-year-old patient? How do I have a conversation about strength training? I don't know anything about strength training. And again, that's where having, well-trained and trusted exercise professionals to connect patients to can kind of like, I'm giving you the ball. Here's the ball. You take the ball and help my patient to actually be successful, in terms of starting their journey towards the integration of regular physical activity. So, the physical activity vital sign is a great place to start, super important. And, then it's going to be the rest of the work.
Yeah, and just to say Graham, I don't mean to jump in, but I think to Liz's point, like the next phase of our work is going to be on the quality and performance measure development that incentivize that discussion and try to, align the incentives with, making this part of a standard of care. But to Liz's point, the core measures that we were able to get into the physical activity, into USCDI were the 2 questions on aerobic physical activity that translate to minutes of moderate to vigorous physical activity per week, and then how many times per week do you do muscle strengthening? So those are the core measures that should be going into EHRs, and they're aligned with the physical activity guidelines. They're validated and in the literature. So that was really important. They were evidence-based in this work.
Sure. So Jeff and Laura, from a an employer or facility perspective and the practitioners, what are those tasks that you see that are essential to help move this forward?
Yeah, I'll go ahead and go first on this one. I think what Liz was talking about is, working on the workflow. It's imperatively important. Like you said, if it's fantastic that we're able to create this, but if the practitioners don't use it, no one's going to get the benefit from it. And so, in my experience, at my Valley Health location, we are integrated in the health record for the health system that we're at right now. And what we did was create an order. So our providers could just put an order. It's called REF 555, and once they put that order in, it's sent here to the medical fitness center. My sales team then gets that referral and then contacts the patient to get them in. They get a printout of all the information about what we're going to be talking about and offering. But what's really great about that is, what I say is, it lets my dogs hunt. You know, we get the referral in here, and then my team's trained on how to get that individual in for a tour, to feel comfortable about the center, to get them into our exercises medicine program and see that this is a facility that everyone in here is very similar in the same situation that they are in. And they see all kinds of individuals. So I think getting it built into the workflow is extremely important aspect of that.
And then to take it one step, I'm watching it kind of filter all the way down. I come down to the academic side, and here I am being the educator for these individuals and saying, hey guys, the workforce is needing individuals who can do X, Y, and Z, can integrate exercise, know what enough exercise is for that individual, what's safe for that given individual. And so we are looking at expanding our curriculums again to help tailor that, become to facilitate individuals in getting accredited or certified, depending on what certification level of certification they're interested in doing, and making sure that they are at the sufficient level that a physician like Liz could feel comfortable sending the information along, and somebody like Just Facility would hire an individual, whether it be at the master's level or at the bachelor's level, depending on what certification they're interested in doing. And so understanding all the different assessments, taking that assessment and knowing how to say, okay, this person's at this level, they need to be at this level. What's the progression? What's the volume? What's the safe criteria to build? What's a safe work zone for these individuals? And so certification and education is a must to get these individuals on board. But it's also not only those that want to be specific exercise or fitness professionals, as we mentioned, occupational therapists, physical therapists, knowing that their clients are in need of something more, and to be able to say, hey, you need something more, we need to refer you to a facility that's going to facilitate more of your exercise health component to it, beyond just what I'm doing here for, your knee replacement or occupational therapy or whatever the case may be. So it is a team building and a foundational understanding of what healthcare providers can do for all.
One of the underlying themes that I hear here is a education, training, and resources, whether it's for the referring professional around what the assets and the human capital are to develop and deliver these programs. For the facilities, it's around how to receive, how to process, how to direct individuals to the programs that are going to be most relevant for them. And for the professionals, it's really around how to work at that intersection of clinic and community, and provide the necessary feedback to the physician and design those programs that are going to best meet the needs of the patient or participant population that they're receiving. And in each element, there's gaps based on how everybody's been trained and prepared so far. So who's doing this well now? You know, who are the pioneers in this? Liz, you talked about a couple of health networks and payer groups earlier.
Yeah, great question. And I guess I'll start by highlighting the work that Dr. Jennifer Trilk has been leading at the University of South Carolina at Greenville. And she's created the EIMG, or Exercises Medicine Greenville program, which is, it's about training healthcare professionals to actually be aware of the importance of physical activity in patient care, and regularly assessing and connecting people to physical activity resources. She's also built a network connecting the primary care clinics to fitness facilities in the community. And they have referred hundreds of patients out of primary care clinics into community facilities, the majority of which are employing EIM trained exercise professionals. And in fact, I was on two calls with Jennifer just last week. And they have more referrals than they have exercise professionals. And so now we're, working with her to try and figure out how do we, again, this is an iterative process around how do we best prepare people to actually receive referrals from healthcare providers, recognizing that the people coming in, some are low risk, some are moderate risk, some are even high risk. But I think they're generating between 70 and 80 referrals per month, which is quite phenomenal. So definitely the program that Jennifer has built, and she's working closely with the White House as well, as this is just an exemplar program of connecting healthcare to health and fitness. And before I kind of like hop off my podium for a minute, I just want to talk a little bit about and build off something that Laura was sharing around, referrals from other healthcare professionals into a health and fitness environment, and specifically physical therapy to physical fitness. Exactly that person who has had a knee replacement, and had post-operative physical therapy, and now has graduated from that program. And then, I mean, most of the time it's just like, you're done, right? Go figure it out on your own, right? But why don't we have a more connected process, connecting that person who just, had a knee replacement? I mean, why do people have knee replacements? Because they have pain, and pain restricts them from actually doing physical activity. So that connection between physical therapy and physical fitness is super important. And then one that Lori and I have been talking about recently is making that connection from people who have been in cardiopulmonary rehab into, fitness. And, heart disease, again, it remains the #1 killer, of people in the United States and globally. And an incredibly small minority of people even do any cardiac rehab at all, let alone finish cardiac rehab. And I think a consistent referral from cardiac rehab again into fitness is low. It's probably close to unmeasurable, and we need to do so much better, with that, in order to try and reduce the morbidity and mortality, related to heart disease.
Well, and as you're really highlighting here, discharge to home program, having come out of clinical settings, is really a critical element in terms of long-term success for the patient around adherence, and given what most insurers will provide in terms of reimbursement for rehabilitation, it's not nearly long enough or intense enough to support the positive outcomes that they're looking for. And Laura mentioned earlier the idea of matching the qualifications and the education to a participant based on really the level of oversight and attention that you determine is necessary. Is it physician supervised, physician referred, physician cleared, or physician recommended, just for those individuals that need a little accountability and creativity to support their efforts.
And maybe just, I'll just mention one more thing. Sorry to interrupt. But I can't help but notice that Brad Roy is on the webinar today, and I just want to do a shout out to Brad and, you know, the work that he's done up in Montana, you know, that
Yes.
really has integrated, you know, that later phase cardiac rehab, you know, into a fitness facility that makes it easy. It's reducing barriers and creating a frictionless experience for people to go right from cardiac rehab into kind of community fitness. So as we're looking at exemplars, not only is Dr. Trilk, but Dr. Roy has created an amazing resource for the community with his program as well.
Agree. Lori?
I think to respond to a question Ruth asked in the Q&A as well, and that's why I was going to take what, you know, Jennifer's great work and the coordination across the White House commitments. You know, the key thing, what Jennifer's done well is she has worked with local Ys who scholarship people who can't afford to stay in, you know, part of, you know, to pay for the Y membership to stay involved in their exercise prescription. And so she has solved a problem there, but it's not a sustainable solution that we can scale nationally. We have to talk to the payer community, and that's another aspect of our work. We are working with Avalier right now, who's helped us develop a strategic roadmap for integrating into and penetrating the payer marketplace. We've got, and we just got off a call with CMS and the idea of, you know, exploring options for Medicaid coverage. We've got to reach populations that can't necessarily afford these services to be able to allow for these seamless transitions. So it's a really important part of this, and we're on it. It's going to take a little bit of time to get it right. And what we have to come back to the agency with, and this is what I'll just say, that as we talk to regulatory agencies, we have to come with a sophisticated benefit design for whom, for how long, for what conditions, and what is the reimbursement that we're thinking is right. And we have to figure out if we're going to piggyback on existing infrastructure like the cardiac rehab infrastructure, medical fitness facilities. I don't think it's going to be possible right now to get qualified exercise professionals to be able to bill directly for their services. I think it's going to they're going to have to be embedded within a team, a value-based team that's delivering the service as either part of a medical fitness facility or part of a healthcare team. And how do community-based organizations fit within that? We've got to figure that out. But all to say, continued conversations with CMS and the payers. It also is going to become imperative that your field is really clear on who has the certification to deliver that supervised exercise therapy. Clinicians have to be comfortable. And, you know, I'll say on the nutrition side, it is the registered dietitian, one title. We don't have that singular title for the qualified exercise professional, and that is confusing. It's really hard to go into these conversations with the payers without a really clear description of who's part of that healthcare team.
Sure. That's where that NERF helps a little bit too, because you span the clinical health, fitness, and performance spectrum, and you can point to those titles. Lori, you hit on something that's important on that, is the areas that still need development. And clearly there's some work on the technology programs, the other stakeholders that we need to engage, including the payers. What do each of those areas look like or are top of mind for each of you?
It's the payer, I just say quickly, it's the payer community, it's the digital health technology solution. So that, you know, that sector. It's also the organizations that do quality and performance measure development, i.e. NCQA and HEDIS measures, for example. And then it's going to be other regulatory agencies that help with payment, like CMS, working with the private insurance marketplace and employers. So those are some of the key partners we've identified in our next steps.
And on the payer side, I think some of the things that we've heard consistently is they're looking for a program that's scalable and reproducible and outcome-based, or at least reasonably designed, where they would have a single payment event associated with the completion or reasonable completion of the program versus a per intervention or per session based.
That's right.
That.
And I think we have some, we have some clear disconnects, right? I mean, even with, the Affordable Care Act says that commercial payers have to pay for services that have an A or a B rating from the U.S. Preventive Services Task Force. And for people with cardiovascular disease risk, accessing resources that improve their nutrition, physical activity, and support weight loss when indicated has a B rating from USPSTF.
Mm-hmm.
It does.
Yeah, nobody's paying for it yet or has identified what it is that they.
Well, they might be paying for it, but it's a question of, I don't think they're paying enough is part of the problem. And I don't know if clinicians know about that and it is not consistent across all Medicaid programs and across even in the private market, what that lifestyle behavioral counseling looks like.
And so we do have, we have some successes with, our Medicare Advantage plans, require a wellness benefit,
Mm-hmm.
which generally is translated to a fitness benefit. And I think probably most, if not everyone on this call probably is aware of the Silver Sneakers program. And we hear a lot about that. And, they've done some, fabulous work, just looking at the evidence of, participation in Silver Sneakers and how it decreases healthcare utilization and cost.
That's
And
right.
so, that's, it's really having that discipline, to study and have robust evidence that gets, organizations like CMS to say, yes, we think this is valuable and we're going to have policy changes that support payment for this.
Thanks for saying that, Liz. That is absolutely critical. What we've heard from the payer community is you do have to show that cost effectiveness, and it's got to be with hard outcomes, especially with CMS. It can't just be our patients felt better. You actually have to have reduced their their medications for hypertension or improve their prediabetes, or they have to be hard clinical outcomes that convince payers to pay for this service. And so that's a cost effectiveness analysis, which we're starting to do right now. We're starting to get our arms around that because we have to bring that sophisticated evidence base to the payer community. And if you're talking to the individual marketplace, the private insurers, you've got to show that return or value on investment within 1 to 3 years because patients are moving through different healthcare plans based on their employment status often. And then, with the Medicaid market, you might have a 3 to 5 year window to show that return on investment. And with Medicare, you've got a longer runway because you have those folks for a longer period of time. So you can go out to 10 years. But all to say, we need to be able to show that if you refer to the qualified exercise professional who's part of that value-based team, the service that you provide actually helps improve hard health outcomes.
And I'll give, I think there's one more example of this, that I think is such a good one, and it's a good roadmap potentially for us to follow in the physical activity space. And that was the CMMI, or the Center for Medicare and Medicaid Innovation grant that was done, study that was done in the WISE for the diabetes prevention program.
Mm-hmm.
That was a perfect example of taking an evidence-based program, implementing it in a community setting, and being able to look at cost savings. And, it exceeded $1,000, at 18 months. In fact, it was close to 2,000, if I recall correctly. Those are big numbers when you think about the number of people, who are on Medicare. And that, of course, has had a trickle-down effect to now we have more than 30 states that are paying for the DPP through Medicaid, state
Mm-hmm.
Medicaid, which is an 80-20 split. So, we don't want to have a runway that's quite as long as DPP, since it was published in New England Journal, I think in 2000. And, here we are at 2024. So we don't want that long of a runway in physical activity, nor do we need it. But it's a great example of, again, having a great research design, the right kind of outcomes that influence policymakers, that led to a significant shift in coverage.
Sure. And, I think that we spent a lot of the early part of our conversation really talking about those things where there are either gaps or opportunities. And I think what the pivot is right now is talking about celebrating some wins. And clearly the programs like Silver Sneakers and the Diabetes Prevention Program are kind of at the front end of that. What are some other wins that each of you see right now, things that we should be celebrating that are moving, moving us down the field?
I think, there's a lot of momentum right now around food as medicine, Graham, and I trying to have conversations with the White House and others who are part of all this, that let's walk our, let's have our work walk alongside and be parallel to that, and let's learn from each other and amplify each other's efforts. I don't think we're there yet, but I also am trying to thread that needle because right now, food as medicine has the attention of this administration and this White House, but we're in an election year, and I don't know how things are going to change or not come November. So, sometimes those kinds of parties, we've seen those parties come and go because of political headwinds. So, all to say, I'm trying to make our work sustainable over time underneath the polarized political environment, getting the sustainable regulatory change that makes this long lasting. Um, so I think it's, we take advantage of those opportunities and momentum where it's happening, but we also do the work in collaboration and coordination to make this sustainable and affordable over the long term.
What are some other perspectives on wins that we should be celebrating?
Well, I would just say, just in the fact that the Medical Fitness Association's been around for more than 25 years, and those facilities have been doing this work kind of in the background where most people didn't know. So I'd like to highlight that as it's a way to get it done. As we just mentioned, Brad Roy's on the call. He's been a leader in that aspect, especially in the Medical Fitness Association, in getting our programs up and moving. And many of our facilities have robust outcomes and can report outcomes. A key success, I'd say, is the company I just now started working for with Power Wellness. We manage 30 centers around the United States, all of which run these medical integration programs, and we're able to take all that data and provide outcomes and real-time outcomes on 5,000 patients every year. And so much so that we did publish not too long ago some of our outcomes and stuff. So that'd be a key success.
Laura, how about you?
Well, definitely coming from the academic standpoint and getting credentialed and getting the credentials to be at a level that physicians will feel comfortable referring to. So, for example, the American College of Sports Medicine has a clinical exercise physiology certification, and in that level, you need to have graduated from an accredited program, so that trickles down into the academic world of making sure that the programs are providing the educational basis that they're going to have that foundation to be able to take the certification. And that's at the highest level for high risk individuals for supervision. But even trickling it down to even the certifications as an exercise physiologist or as a fitness instructor, making sure that we get, as Lori mentioned, maybe one title for each level of low, moderate, and high risk individual is a direction that we're making strides, but not quite there yet. And so hopefully, this is directions of where we're going, and with the help of all these programs and initiatives, it's going to eventually parse out and be able to get us in the right avenues.
Okay, thank you. Last question before we answer some questions from our participants here. What does success look like over the next 24 to 36 months? Just real quick round robin, maybe starting Jeff with you.
I think success really is just getting more people aware of what's going on. more collaboration. I think if we can collaborate with like-minded organizations, there's a lot of things that people are doing that we don't know. And to get all those individuals together might be able to solve this problem sooner. So I think that would be a success to look for.
Okay, just going around my my Hollywood squares here, Liz, that would be you next.
Well, I think one area of kind of low-hanging fruit is we created an online exercises medicine training program that prepares people to sit for the EIM credential. And certainly the pandemic accelerated access to online learning, asynchronous online learning. And, you know, a lot of credit goes to Robin Stewart, our former vice president of exercises medicine, who largely created that. But I think that's a way to help our existing exercise professionals who may not feel as comfortable receiving referrals from physicians, for them to really enhance their knowledge in this space and feel like they're better prepared to work with healthcare providers and to receive referrals. So you can check that out on the exercisesmedicine.org website.
Right, thank you. Laura?
Piggybacking on what Jeff was saying, just getting more individuals interested in the aspect of health and being the healthcare professional to be able to provide the fitness components to it. So from an academic standpoint, that's really our drive of the initiative, and where we could see some great strides of getting more individuals invested in that. Of course, that is all their dream goal of being wealthy individuals and having a job that's going to create a comfortable living for them. So it goes hand in hand with that. As we get reimbursement, I think there's going to drive more of the realization that this is a career path that's worth pursuing for those individuals.
Lori?
Well, we've got a lot of important next steps, Graham, and my goal is to see us make some progress in every year of this work. So I think our next real effort is going to be to try to really open these conversations with NCQA and get funding to start that work. We will need to bring funding to the table to do that work. So we've got to do quality and performance measure development with NCQA, get the funding necessary to do that. Also see if we can talk to some states or health information exchanges or payers to pilot, maybe a USC Greenville and other states, or other kinds of models, maybe even digital health solutions with Medicaid and even the private marketplace, especially with the employer community. So that's another to do. And then I'll just say really quickly that we are building a reference implementation, which is an app that allows you to connect to our implementation guide and allow you to receive and exchange data with potentially health systems or payers or other end users. And it's going to be in the testing environment in spring of 2024, and then we hope to be able to release it into the public domain in the fall of 2024. And I think that'll be a valuable asset for your community to use so that they can start to embed it into their practices.
Terrific, thank you. So I see that there's a couple of questions to put out to the group, and I see that there are some that have been answered. Lori, Francis Narek is asking if the PA has worked with healthcare economists to clearly articulate the cost benefit for payers.
Thanks for asking that question, Francis. We're actually doing that work right now. We're convening a writing group, and if you have anybody that you'd recommend to join that effort, let us know. But we're convening that writing group to look at all of the literature and do that analysis to be able to bring that to our discussions with the payers, both private and public.
Let's see. We have a number of questions that are related to really to the military sector and to the VA. On that, I guess the kind of merging some of those questions. what are we doing alongside the Veterans Health Administration around working with their whole health program or other physical activity?
Yeah, we've actually talked to the Veterans Administration, a couple different teams, and actually it's time for us to check back in with the VA and see if they were very interested in our implementation guide and looking at how to integrate that into some of their health screening and some of their programs at the VA. So we need to check back in and see if we can do anything more to support their effort to integrate and see if they're interested in going further. The VA is, and I would say the military sector of our National Physical Activity Plan is phenomenal. They've been really active over the last couple of years, engaging with military leaders. We had a meeting at the Pentagon last year, and we're able to introduce the plan and kind of the recommendations and tactics in the plan that I know are so important to military leaders as they struggle with recruitment and retention efforts right now, and fitness is front and center for them.
Sure. And then I see a question from John Holland here, and he's asking about leveraging the expertise of recognized professionals across a broad range of credible credentials. And John, that is why we created CREP and US reps and have worked collaboratively with the other members of the Physical Activity Alliance to develop that national exercise referral framework in the construct of meeting the triple aim of medicine, of cost, access, and quality. We need to be able to accommodate the needs of individuals along the full spectrum of both health status and their interest in physical activity or performance. So we're hoping that vehicle is used for the positive verification of the credentials of the individuals that are best positioned to provide these services. And there will be some variability based on those that have more complicated health conditions where it would be a combination of education and credentialing. This is an interesting one, and I'll direct it to you, Lori, on this. It's for the Physical Activity Alliance. Do many clubs utilizing the CPT codes for health and wellness coaching?
That's a great question. The Health and Fitness Association just had their convention last week. Graham, you were there, and maybe you could talk about how this is front and center for, I think, the fitness club industry right now. And
yeah, and the CPT codes that are available for health and wellness coaching are Category 3 codes, which are really used for data collection. The purposes of those is to determine the efficacy and if those should be moved to a reimbursable status. And within commercial fitness facilities or just membership facilities in general, whether for or not for profit, health coaching broadly is not a line of service that they've established to any great effect. Where we see the greatest utilization of those codes is in the organizations that are providing supplemental benefits. Ones like WebMD, they're working with individuals with poorly managed diabetes or hypertension, and they're hiring health coaches that have an underlying nursing credential usually, and they're involved in the telemedicine provision. So especially in the construct of the pandemic, when in-person service was difficult, I think when you're looking at the broad category of health interventions, health coaching is something that's going to grow over time.
And to Ruth's question, Dan Bornstein and the military sector are definitely they are very aware of that program at the VA and are interacting with a lot of the folks that are part of that program.
All right. Anybody have any final thoughts that they'd like to share? All right. Well, we're right at time. So thank you very much to all of our panelists and the participants that joined us for today's conversation.
Thank you.
Thank you.
Thank you.
Have a good day, everybody.